brought her with her to the job. I need to get bigger. There we go. Okay. Brought with her to the job extensive experience in the recruitment, engagement, management, and retention of volunteer communities, having worked for multiple nonprofit fundraising campaigns. That's terrific. We'll have one coming up in a few years and reach out to. Particularly passionate about educating students about hospice and palliative.
Correct.
Palliative care. Wow, that's a word I've never heard. Okay. Alicia works often with universities such as CSU East Bay, had a daughter graduate there. San Jose State, had 2 daughters graduate from there. And Stanford, nobody graduated from there. So Alicia.
Thank you. Yes, good morning everyone. I appreciate the opportunity to speak this morning. Thank you so much for breakfast. That's a nice benefit. So I'm here today from Vitas Hospice. We're just down the hill. We have a satellite office by GoPro at the bottom of under the college. I don't remember which street that is, but Hillsdale. Yes, we're on Clearview there. But we provide end-of-life care to patients in a home-based setting. So we care for about 150 patients between Mountain View and San Francisco on your side of the bay, and about 300 patients within Santa Clara and Alameda counties. We're the nation's largest hospice provider, and we're caring for about 16,000 patients throughout the United States today. So we started in Miami and have care teams throughout the nation. So I just came today to talk to you a little bit. I think there's often some misconceptions about what hospice is. So I came today to talk to you a little bit about what hospice is, how you or your family can benefit from the hospice benefit. I did bring some information for you to take home with you. I set it back by the coffee. One of the tools I brought today is the 5 Wishes document. Mike and I were talking about what kind of tool, how you make your choices for yourself at the end of life. And this is a document that literally walks you through that choice system. What do you want to happen to you when you can no longer make choices for yourself? It's a great resource for your family because, as Rob mentioned, I did care for my grandmother and my father at the end of their life, and my father's plan for himself was for somebody to take him out into the woods and shoot him. And unfortunately, that was not an option for us. He did spend his last month in the VA in San Francisco, but that last month was easier on me, as easy as it could be to lose your father, because I knew what his choices were for himself. That he did not want to be intubated, he did not want to be on life support, he did not want to be a burden to us. And so this is a great resource for you and your families. So hospice is a Medicare benefit. So 100% of hospice is covered by Medicare if you're Medicare or Medi-Cal eligible. And so we come into your home with our doctors and our nurses, our social workers, chaplains, home health aides, and volunteers, which was my role, to support you and your family as your loved one makes a transition towards a natural death. So I'll talk a little bit about hospice today. So unfortunately, death is inevitable. It's one thing we all have in common here, right? 10% of the population have a sudden or unexpected event, such as a heart attack, accident, or catastrophe. But more than 90% of the population has a life-limiting illness over a long term. And so that slow decline is really usually where hospice comes into benefit in helping you and your family to manage the crisis associated with that illness. When we ask the public what they want for themselves at the end of their life, they want to be cared for in their home. There are some very lovely facilities, on El Camino that people love to live in, but if you can be in your home, if you can be surrounded by your loved ones, be in continue to have the quality of life that you had previously, it leads to the quantity of life. So when asked of Californians in 2011, 70% of patients wanted to die in their home. There was a percentage who wanted to die in the hospital. That is usually associated with culture and or not wanting to be a burden to your loved ones. There are those who have refused to make that choice, and then there are those who want to go into a facility. And so we are not a hospice facility. There is a building where we care for our patients. We care for our patients at Sunrise of San Mateo. We care for them at their home down the street. The only two hospices that I know in the Bay Area, and it's very weird, there are many, we have 50 different hospice providers here throughout the Bay Area. But the only two that have a home are Zen Hospice in San Francisco or George Marks Children's Home in Castro Valley, where they specialize in if a child is nearing the end of its life, the whole family moves into their home. So what do patients with serious illness want? Pain and symptom management, and that really is what hospice is about. It doesn't matter what you have, it matters how it manifests itself in you. Do you have shortness of breath? Do you have swelling of the limbs? Do you have pain associated with your disease process? We're going to manage those symptoms versus your disease process. We give you a sense of control. Many times I recruit volunteers to support our patient population for quality of life measures. And many times that's distraction because someone doesn't want to take their pain meds. If you only have so many days left and you don't want to spend it sleeping or groggy because of that pain medication, I may have a volunteer who comes in and entertains or engages our patients so that they can avoid that kind of focus on that pain management. They want someone to appreciate their life legacy, and they want their loved ones supported. And that's one of the wonderful resources of hospice, is that ability for our care teams to come in and manage the patient's pain, but also manage the feelings associated by the family, which are obviously one of loss, one of unknowing, one of being scared, is to understanding what's happening to their loved one. Our caregivers want help. They want help emotionally and they want help physically. And so there is that education that associated with teaching them how to perform the care that their loved one needs, and also providing that listening opportunity for the family members. So hospice is when someone is diagnosed with a life-limiting illness or 6 months or less to live. That doesn't mean that if someone comes onto service that they succumb within 6 months. We've had patients who've been on service for years. It just means every 6 months we have to make sure that you're continued to be eligible, as our federal government is going to pay us to care for you. And so we have Alzheimer's patients who are, yes?
Who makes that determination?
Who makes the determination of what?
Whether you're eligible for it or not.
A doctor. So it could be your doctor, it could be the doctor if you live in Sunrise of San Mateo, it could be the doctor who manages that facility. Yeah. And that is reassessed, as I said, every 6 months in case you do go home and you do get better and you do start to gain weight, and sometimes you just had a declining incident versus a declining decline that's leading towards the end of life, and people come off of hospice because they are stabilized. Again, this is considered the palliative environment, not the curative environment. That doesn't mean that we're going to stop treating your illness. It might mean that you don't do chemo, it might mean that you don't do dialysis, but that doesn't mean that you stop taking your Lasix or your heart meds or those sorts of things. It isn't giving up. So Medicare is a hospice benefit. It was enabled in the 70s. And part of that hospice benefit is the use of volunteers in a program. So that's why I have a job. We are a for-profit hospice. There are many for-profit hospices, but we're all regulated by the same industry. But we utilize those volunteers not in replacement of paid professionals, but in collaboration with, again, for that quality of life measures. So we have patients who don't have family present, and we have volunteers who support those patients. We have them for patients who may be monolingual and live in a facility in which no one else speaks the language that they speak. Or we have a lot of volunteers who visit the caregiver because their loved one has Alzheimer's or dementia and sleeps 22 hours of the day, and it's very isolating for the caregiver or loved one or spouse. And so we have that volunteer to add compassionate care for that patient. So how do you refer to hospice? Usually a referral to hospice comes from either a doctor, a care system. So as I mentioned, we previously have a relationship with Stanford. So Stanford and Vitas have a relationship that if you go to Stanford and have a life-limiting illness and you do not want to continue to pursue a curative environment, maybe your chemo is done for you, there's no more that can be done for you, or so on and so forth, they will refer you to hospice and we will follow you home. We also have a relationship in Good Sam and RMC, where if you were diagnosed with a life-limiting illness in that facility, you could either move to our floor or we will follow you home. So we develop a plan of care in regards with the goals that you have for yourself in mind. So I think that's one of the wonderful differences between the curative and palliative environment. If you go to the doctor's office, they usually tell you what to do. In the palliative environment, we give you suggestions and then allow you to make choices for yourself. So the basic hospice Medicare certified benefit are physician services, nursing services, crisis counseling, home health aides for bed baths, showers, light housekeeping. We do have bereavement services, so sorry, I'm a mover, I apologize. We do have bereavement services, so after our patients have passed away, we'll have support groups for our families. We provide the diapers, the wipes, the chucks, the medications, the wheelchair, the oxygen, all of that. Even if you live in Sunrise of San Mateo, all of that comes from us when you're put onto hospice. And then we also have 24-hour support service. So our physicians are very, you don't stop seeing a doctor just because you've come onto hospice care. They're very much a part of your plan of care in regards to your disease process. Nurses really run the show in hospice though. They are really the boots on the ground, visiting you on a weekly basis or multiple times a week, depending upon your needs. We also have after-hours nurses and weekend and what's called intensive comfort care nurses for those who are having unmanaged symptoms. I just mentioned that. We take into consideration the psychosocial proportion of end-of-life care, the grief associated with it, both in the patient and in the family, and have a social worker and a chaplain to support our families. And our chaplains are Master of Divinity educated professionals associated with religion, but they don't have to necessarily be there for someone's religious beliefs. They could be there as a therapeutic ear. But we do have, I like to say one of every faith, but we have a rabbi who works for us. We have a Buddhist monk who works for us. We have all of the all of the different Christian faiths who support us, so that we're educated as to the rites and rituals associated with your belief system and can honor those in your end-of-life journey. The cultural diversity of the Bay Area, it's very important for us to take that into consideration when going, especially because we're going into your home to care for you and your loved ones. As I mentioned, our home health aides are really there to provide light housekeeping, bed, bath, shower, those personal care needs that our patients have. And just because, as I mentioned, just because you're on hospice doesn't mean we stop caring for the rest of your needs. We incorporate physical therapy, occupational therapy, speech therapy, dietary support, and respiratory therapy for those patients who have a need. We do provide respite care, and that will allow, say, a loved one you're caring for your loved one. I know many of you talked about traveling for the holidays. You're caring for your loved one in your home, and you need a break, or you're going to take a little vacation or that sort of thing, and so we'll then pay for a week for the patient to reside in a facility for you. Bereavement services, as I previously mentioned. So volunteer participation. As I mentioned, my role in regards to hospice is volunteer services. And so I reach out to the communities. Rob talked about in my introduction, my relationship with the schools. We utilize a lot of different interns in our social work programs. We have rotation from Stanford doctors. We have CSU East Bay. I have a couple of Masters of Public Health students who are assessing the work that we're doing. But we do have regular lay people, people who are interested in supporting our patient population because we cared for their loved one and they want to give back, or because they have a particular interest in supporting the geriatric community, and or many people come to us because they're interested in documenting the stories of our patient population. I talked about my care for my grandmother upon her passing. She was 103 when she passed. I like to think she got there because of me. But she was born in Berkeley in 1908 and succumbed in Oakland in 2011. And so she lived more or less in the same community for that 103 years. So that's the Bay Bridge being built, the Golden Gate, the Roaring 20s, crash of Wall Street, cars, computers, phones, all of those things were created in her lifetime. And I think one of the wonderful resources, and hospice was not introduced to me by her care team, even though it was our plan for her to die in her home, because she'd been in her home for 60 plus years. It wasn't until I came to work here that I realized that hospice would have been a wonderful resource for me and my family, because I don't have a medical background. And not only was I caring for her, but I was caring for my father at the same time. But a wonderful resource, had we utilized hospice, would have been to document some of those stories, because she had wonderful stories that at the time I felt I would know forever, because she told them to me so many times. But today I don't know that I can tell you, unfortunately, because we didn't write them down. Plus, she has some of the memories of where my great-grandparents had immigrated from. I could tell you the country, I couldn't tell you the city. So those sorts of memories that are associated with our, that population, we don't want it to leave with that. We do provide everything, as I mentioned previously, the drugs, the medical equipment that our patients need, no matter where they live, private home or facility. And 70% of our patients actually live in facilities, so skilled nursing, assisted living, board and care. There's a large board and care community here on the peninsula, and that's a converted home that's going to be converted into a care home, and that's where a lot of our patient population comes from. So we're one of the things that sets us apart from our competitors is the capacity to bring on patients 7 days a week, 365 days a year. Somebody asked me if I was getting Christmas off, and I mentioned, sick people don't take holidays, we don't take holidays. And we do have the opportunity as a for-profit hospice to do a lot of charitable work. So we do take on patients. We did over $9 million in charitable work last year as an organization, taking on patients who aren't Medicare eligible because of age, but are dying because of their disease process, and caring for them. We do take patients who are undocumented, and so caring for them. We do have patients, we've worked with a lot of Gift of Love in Pacifica, which is it's run by nuns. It usually takes on a lot of patients who are formerly homeless and are now at the end of their life, and we pay for the care that they receive there. So one of the reasons that hospice was created is because they saw with certain disease processes that there was a significant uptick in readmissions to hospitals, people going to the ER to manage their chronic illness. And that's very expensive. It's very expensive on the hospital systems, it's very expensive on government systems, it's very expensive to everyone. And so hospice was created in regards to that, to create an outlet for readmissions to hospitals. Unfortunately, the cost of dying is very high, and it's just going up. And so, chronic illness currently accounts for approximately 32% of total healthcare spending in the United States. The sickest 5% of population amount for almost half of all healthcare expenses and about $5 billion in Medicare. Hospitals have long argued that the average length of stay figures are skewed by patients who are no longer responsive to curative treatments. Often families report after death that their loved one never wanted invasive treatments during the last 2 months of their life. Hospice professionals can provide key patient advocacy that helps to save the patient and family from further trauma. So we really are about the quality of life at end of life, not quantity. So we have a lot of patients, the disease process that associated with end-of-life care is very commonly thought of as your cancers, your livers, your hearts. But their hospice care is a significant contributor to supporting their patient populations with Alzheimer's and dementia. It isn't easy to see when the end might be near for somebody with that disease process, but it is a great resource for those associated with the disease process and their families because the care is needed over a significant length of time. So as I mentioned previously, I brought two flyers, one that talks about what your choices are in regards to your family so that they know when it comes time and can help you to make choices. Additionally, I brought for you the pamphlet associated with what does the Medicare hospice benefit do for you? As we age and become Medicare available to us, knowing that this is a resource that you don't have to consider out of pocket, that this is a benefit, a government benefit to you, I think is a misnomer. And so one of the reasons that I brought this pamphlet to us because people often wonder how they're going to pay for this sort of resource. So as I mentioned, the hospice is 6 months or less to live, but there are those patients who come on who've been with us for multiple years. Additionally, there is that opportunity to come on to hospice and to have your situations regulated and then to graduate from hospice for extended prognosis, which I think is a wonderful resource for our families who are in crisis mode, and be it that it's just going to end up being a short crisis, hopefully. So as I mentioned previously, we have an office here in San Mateo, San Francisco, and Milpitas, and cover patients in Alameda, Santa Clara, San Mateo, and San Francisco County. But we're one of 2 resources here in the Bay Area. We also have a sister program that covers Contra Costa County and whatever county Lathrop is in. Tracy, what's that? Stockton area? Wherever that is. I know where it is, but I don't know what county it is. So, out there.
Out there.
Tracy. We also have a program that covers out there in the Central California. Way yonder, it feels like today. Anyway, thank you for having me this morning. I appreciate it. Yes, sir.
If somebody's on hospice, could they go on vacation?
Physically?
Yeah.
Yes.
Okay, I mean, that wouldn't prevent them since the doctor said,
Right.
could they still?
Yeah, no, we've had patients, especially around this holiday, who've traveled.
Okay.
Usually it's, if there's a plane ride involved, there's got to be a little bit of, you've got to ride with a letter of documentation,
Sure, yeah.
that sort of thing. But oftentimes, so we just had a woman who went to Sacramento for Thanksgiving, And we informed our Sacramento program that she was coming, and they took over her care for the week that she was in Sacramento for Thanksgiving. Yes, sir.
My mother passed in 2008. She spent the last year of her life comfortable in her own home in Belmont with hospice. She graduated from hospice a couple of times. She had heart conditions, so she wasn't in pain or suffering, but she died with dignity and comfort in her own home. I can't speak highly enough of hospice. It's a wonderful concept, and the way it applies in my mother's case was just wonderful.
Right, wonderful, that's great to hear. And I'm sure that brought you great comfort in knowing that she was comfortable, and your family as well, yes.
What do you see in the percentages of the hospice patients of cancer patients and other illnesses?
So I would say it's probably only 30% of our patient population are cancer patients.
What percent?
30%. A significant, a longer portion of our patient population is the Alzheimer's and dementia patient. And I think that, as Mike and I were talking about, I think hope is a wonderful factor, but unfortunately often leads to a cancer diagnosis, a continual trial of finding a cure, in that they're not necessarily willing to give up until the very end. So we do find that of that 30% of our cancer patients, they come onto service for a significantly shorter period of time, weeks, sometimes the last days of their life. They don't think about us until that time. Yeah, good questions. Yeah, so as I mentioned previously, I have the resources over there by the coffee if you'd like to take one with you. Thank you.